Hi, and welcome to the seminar. For those of you tuned in, my name is Shinjini Kundu. I'm a diagnostic radiology resident at Johns Hopkins Hospital. I'm a member of the editorial board of the Radiology Artificial Intelligence Journal and a member of the Radiology Informatics Committee at the RSNA. Today, I'm very excited to be giving this talk using AI and chest imaging to help unravel some of COVID-19's mysteries. We're going to talk about AI and chest imaging in particular first, and then we're going to move on to what these lessons may mean for post-COVID radiology, as well as a post-COVID world in general. So by the numbers, the CDC estimates that since the COVID-19 virus arrived in the United States in January, there have been over 18 million cases and 330,000 deaths. Now, these numbers may sound grim, but at the same time, we must acknowledge the tremendous collaboration and cooperation across the world to innovate at multiple levels to help combat this pandemic. We have had innovations at the molecular level, at the medical level, at the epidemiologic level. For example, at the molecular level, currently, we have 2 FDA-approved vaccines for emergency use, with additional ones in phase 3 trials. At the molecular level, we also have some drugs approved for COVID-19 currently, including remdesivir, as well as others that are undergoing trials. At the medical level, COVID-19 has certainly provided a tremendous use case for rapid innovation in healthcare and healthcare delivery to scale up response and deliver the most effective and accurate care for large numbers of sick patients. And certainly, radiology is an important piece of that puzzle. In today's talk, I'm going to talk about 3 points. The first is chest imaging in COVID-19 diagnosis. Next, I'm going to talk about how AI could help expand the role of chest imaging beyond just the diagnostic realm to other aspects of pandemic response. And third, I'm going to touch on some lessons that we've learned so far from this pandemic using AI and imaging in radiology, and what this could mean for a post-COVID future, as well as post-COVID radiology. So before I begin, I have nothing to disclose. Some of the opinions in this talk are based on an editorial article that I authored in the journal Radiology Artificial Intelligence, as well as updates and developments since then. This is a rapidly moving area. This talk is not meant to be a comprehensive review of the literature, but this talk does touch on a couple key concepts and highlights a couple key points. From the industry point of view, there are also several companies working on AI-based solutions in the workflow. Again, this talk is not meant to be a comprehensive review of the technologies that are out there and produced by industry, but it is meant to be sort of a sort of distill down some key points and talk about important lessons for the future. So the first part of this talk, chest imaging in COVID-19 diagnosis. So although chest imaging is not recommended for initial diagnosis of COVID-19, the molecular test, RT-PCR, is still the recommended first-line gold standard diagnostic test for COVID-19. But chest imaging certainly has an important role in grading the severity of the COVID-19 pneumonia. For example, we certainly see some findings in the early phase of COVID-19 pneumonia. We see findings such as peripheral, rounded, ground glass opacities in the lower lobes that are pointed out by the arrows. And kind of later, we see other signs such as crazy paving, and we see reverse halo sign. These are kind of later in the course of the infection, but this is also part of the disease pathophysiology of COVID-19 pneumonia in the lungs. Now, very interestingly, crazy painting is not a typical feature seen in most viral pneumonias. And at the same time, some features seen in most viral pneumonias, such as tree and bud nodularity, are not seen in COVID-19 pneumonia. So there certainly are special findings related to COVID-19 pneumonia in the lungs. And this produces a fodder for technologies using artificial intelligence, classification, machine learning to try to investigate these findings further and also see if they could be used to develop a more automated way to grade the severity of COVID-19. So let me just touch on a few studies that have attempted the problem of automatic classification or automatic identification of COVID-19 findings from the chest imaging. So first, we have some studies in chest radiography. We have a couple studies that have used deep learning and have achieved high accuracy in classifying normal bacterial pneumonia and non-COVID viral pneumonia and COVID-19 viral pneumonia from the chest radiographs. We have another system here, CAD4 COVID X-ray, which is a deep learning system trained on over 24,000 chest radiographs, achieving an area under the curve of 0.8. In this study, using a retrospective test set of patients suspected of having COVID, the authors were able to validate their technique. Now, what we've seen with chest radiography and COVID-19 is that chest radiography has high specificity, but low sensitivity. Furthermore, if we look at the literature on machine learning, artificial intelligence, and chest imaging, the vast majority of these studies are based on the chest CT. So using AI in the chest CT, there have certainly been studies attempting to differentiate COVID-19 pneumonia from other causes of pneumonia. We've had the 3-class classification problem, trying to differentiate COVID-19 pneumonia from other types of pneumonia from healthy patients. We have also had the 2-class classification problem, attempting to differentiate COVID-19 pneumonia from healthy patients. And we've even had studies quantifying new biomarkers and quantitative volumetric measurements of opacity burden in the lung, such as the corona score. Now, as we'll talk about later in this presentation, these sorts of quantitative markers of disease may potentially play a role in triaging patients in the future, but that will be a separate section in this talk. Now, although these studies are interesting, they have a few limitations. The first is that most of them are retrospective. There have been a few studies focusing on prospective systems. Second, we need to include more patient data to increase the power of these studies relative to the complexity of the models. As these models are highly complex, there is always the potential of overfitting to the data, and which means being overly sensitive to some of the noise. And in order to protect against this, more patient data would always be more helpful. Furthermore, COVID-19 findings are timing dependent, so there's a chance that quantifying change over time may be more helpful than quantifying the gross findings. So these are just some potential limitations and directions for future investigation. We do know that there is a need for open source data sets for standardized data where the data provided are trusted, they've been curated, they have been vetted to be high quality data sets. Furthermore, for AI studies moving forward, we also need more standard metrics to evaluate these systems, such as we should look into the training accuracy of these models, specificity and sensitivity, predictive values. And these are all in addition to the standard metrics that we tend to look at, such as accuracy. Now, In terms of point of care ultrasound, which is another imaging modality that has been proposed in COVID-19 pneumonia, we need more evidence, both for its clinical use as well as the use of AI systems looking at point of care ultrasound. One of the drawbacks of point of care ultrasound is that it requires a skilled operator, which might limit its scalability for a large scale response. It may also potentially be a limitation in AI studies where the data may be collected in a heterogeneous manner based on operator technique. But there, at the same time, we have had some studies, for example, PO-COVID-NET, attempting to differentiate bacterial pneumonia, healthy controls, and COVID-19. And this study achieved a sensitivity of 0.96 and specificity of 0.79 for detecting COVID-19. So point of care ultrasound is a potentially interesting imaging modality and one where AI may certainly help boost its applicability at a large scale, but we need more information and we need more data. Now we're going to move on to the second part of this talk. And I'm going to propose that AI could potentially expand chest imaging beyond just the diagnostic realm. And some of the areas in which AI could expand the use of chest imaging: first, triage. So hospital allocation, when there are a large number of sick patients, is a real-time challenge. And there are studies that show that the CT findings may actually correlate with the severity of symptoms and the duration of illness and even recovery. So this lends to the question whether the CT findings could actually be used in a triage process. There have also been other studies that have suggested that CT imaging could be used to discover even new risk factors for detrimental progression. Now, this study was able to detect mild patients at risk for deterioration with 79.2% accuracy and found that certain risk factors such as higher age, hypertension, decreased albumin, lymphopenia, progressive consolidation, elevated CRP increased the risk of detrimental progression, while fibrosis was actually a protective factor. So CT imaging could potentially be used for triage on a larger scale, both in terms of the CT imaging finding, as well as potentially discovering new risk factors that might predict progression over time. Second, the CT imaging could be used for risk stratification. I mentioned that there was a study that quantified the corona score to indicate the burden of coronavirus pneumonia in the lungs. Now, it's an open question of how coronavirus actually progresses in different patient populations. For example, populations with chronic lung disease, populations of long-term smokers. The trajectory of coronavirus pneumonia may be different in these groups of patients, and more quantitative markers may be helpful to quantify the differences. Now, in terms of risk stratification, the burden of disease on the chest imaging may also be a potential marker used to predict ventilator requirements. And this, in turn, may help with resource allocation in hospital settings to make sure that patients get the largest benefit and that the sickest patients are the ones who receive care in a timely manner, while the ones who are at risk of progression or the milder cases are kind of identified. The third area in which chest imaging could be used beyond just the diagnostic realm is in potentially aiding discovery of immune modulators most associated with the lung disease. So we know that cytokines mediate a delicate balance between damaging the lung and fighting infection. And in particular, there have been a few studies looking at IL-6 levels. And in other studies looking at ARDS in the past, before this pandemic, it seems that IL-6 levels may be able to predict respiratory failure in patient with ARDS. Now, it's an open question whether we could correlate the severity of illness with immune markers and see if any new therapeutic targets for clinical trials arise. So there have already been studies looking at tocilizumab, an IL-6 receptor blocker in COVID-19 pneumonia. There's a potential chance there may be other immune markers that may be useful to study as well. And correlating the trajectory of the immune response with the chest imaging findings may be able to identify new markers potentially. And chest imaging is only a piece of the puzzle, as we've seen in some of the applications of chest imaging beyond just the diagnostic realm. So the promise of AI lies in the ability to construct complicated models from broad sources of data to identify customized targets. So when we think about data, chest imaging is one piece of data, but we may also consider both traditional sources of data, such as history, vital signs, lab tests, imaging findings, as well as other modalities that have not been traditionally used in biomedical studies, such as textual processing of the scientific literature, geospatial information. So AI may provide a technique to crunch through all of this data at multiple scales, and derive new insights, of which chest imaging is only one piece of the puzzle. So beyond COVID-19, what could this mean, and what lessons have we learned from this pandemic? Beyond COVID-19, we've learned that we need to move fast in times of pandemic. So the scale of this pandemic reveals the need for dedicated research on approaches that are robust, reliable, and rapid. And certainly, even in the past year, we've made tremendous progress in research and in ways to combat the COVID-19 pandemic. Now, where AI can play a role is that traditional bench research in the biomedical sciences have focused on causal models. They focused on investigating mechanistic explanations. And in all of these fields shown on this slide, from biology to genetics to chemistry and physics even, a lot of bench research is focused on understanding the causal mechanisms behind certain phenomena that we see. Now, this has certainly been a very fruitful approach in non-pandemic times, but in pandemic times, the timeline is a little short. And this is where AI and data-driven approaches may provide an alternate pathway. So AI and data-driven approaches try to understand the correlation between two phenomena, not necessarily their causation, as mechanistic models traditionally try to elucidate, but their correlation. So if we are comfortable accepting that X and Y are correlated and not necessarily understanding the causation, we may be able to accelerate research in the biomedical sciences, and in particular, scale up COVID-19 response and knowledge through artificial intelligence and data-driven approaches. The second thing we've learned is that there's a need for data and research standards, particularly when the innovation cycle is short. Now, the rapid development cycle requires a critical appraisal of the quality of the data repositories as well as of the research. In terms of the repositories, we need to make sure that the data are trustworthy, they're standardized, they're curated in a way that is accepted, and in a way that also honors patient privacy. In terms of the research, we need to make sure that these publications, especially the preprint publications, of which that are proliferating rapidly, actually adhere to scientific standards and guidelines. Now, preprints are a fruitful avenue to get research out there. But we also need to make sure that these preprints and these studies are adhering to accepted scientific guidelines, because they do inform future studies, particularly when there is a short timeline. Now, the third lesson that we've learned is that maybe beyond chest imaging, some of the concepts in this talk may also apply. So in other forms of imaging that are relevant to COVID are imaging of the brain. We know that COVID-19 increases the risk of thrombotic events, strokes, heart attacks, amputations. So we can look at other modalities of imaging, as well as other phenomena in the imaging. And the lessons from the chest imaging in COVID-19 may also apply to these forms of imaging in the future. Fourth, the lesson we've learned truly is how to go from in silico to bedside. Now, this pandemic has given us an opportunity to assess how well experiments designed in silico environments would generalize to real world conditions, particularly in representing the true patient population that will be seen. Now, one of the important aspects of in silico to bedside is the ability to rapidly redeploy technology. Since the time is short and there's an opportunity to leverage the tools that are existing and are already out there and repurpose them for pandemic response. So we're in exciting times because we have the ability to assess this process from in silico to bedside in real time and evaluate how well this process works, which certainly will be important for both future pandemics as well as a post-COVID radiology world. Now, future directions to look into. We now have heard about some mutant strains of COVID. Now, some open questions are, how effective are vaccines against these mutant strains? And do these mutant strains affect the different organs differently? Those are all questions that we have yet to answer. And finally, I'm going to end this talk by really closing on the importance of developing systems for pandemic response. So what we've seen is unprecedented global efforts, collaborative efforts across geography, across disciplines, and even across professions, people chipping in to do their part to help solve COVID-19, which has certainly helped accelerate progress, particularly in this pandemic, which has demanded rapid innovation. And we've learned some lessons, and these lessons will be important both for addressing COVID-19 going forward, for addressing future pandemics, as well as living in a post-COVID world where some of the lessons learned will help shape our practices as radiologists and as doctors. Thank you for your attention.